Welcome and thank you for joining us. I'm Dr. Salima Watfa. I'm one of the trustees for the Pranaya and Arthur McGoffin Foundation. The PAM Foundation, as it's otherwise known, was established with the primary goal of increasing awareness of and removing stigma associated with postpartum depression and other perinatal mental health issues, as well as improving access to services for those women and their families suffering from these conditions. The foundation was formed in the names of Pranaya and her son Arthur. Pranaya was a generous and much beloved mother who dedicated a lot of her time to helping others. Unfortunately, we lost both her and Arthur to postpartum depression, PPD, a condition that affects up to 1 in 8 new mothers. The PAM Foundation was established to continue Pranaya's legacy of positive societal impact. In an effort to shine a light on PPD, I am here today with Dr. Madda Miele-Norton, who is an experienced consultant in perinatal psychiatry and the clinical lead for perinatal mental health at St Mary's Hospital, Imperial College Trust. Dr. Miele, thank you very much for joining us today.
Thank you for having me. It's a real pleasure.
A lot of people may have heard of postpartum depression, which is a form of depression that can develop at any time in the first year after giving birth. But can you tell us a bit about how common it is?
So generally speaking, individuals are very familiar with the concept of postpartum depression or postnatal depression. However, it is very important to highlight that every type of mental illness can occur during the pregnancy and in the first year post-delivery. We know, for instance, that almost 2 out of 10 women develop a mental illness during the pregnancy and the first year post-delivery. We also know, for instance, that 7 out of 10 women will tend to hide or minimize the severity of the illness. And even more concerning, we know, for instance, that suicide is one of the leading causes of maternal death. So we have to start to think about mental illness in the perinatal period. And by perinatal period, I mean from the initial stage of the pregnancy up to the first year post-delivery. Mental illness in the perinatal period is extremely frequent, and we perhaps should consider it as one of the most common medical complications of the pregnancy.
Despite it being very common, as we've just discussed, it's often difficult to spot the signs. Motherhood is a challenging transition with a lot of changes, both physiological and in your routine. How can you spot the signs of postpartum depression, and how does it differ from baby blues, which a lot of new mums experience?
Now, the challenge that we face when we try to identify early signs and symptoms of a perinatal mental illness is that it's very difficult to distinguish early signs and symptoms of a mental illness from what we consider normal adaptation to motherhood. The symptoms overlap. Women who have just had a baby often feel sleep deprived, irritable, they might feel changes in appetite, they feel easily overwhelmed. The difference, however, is that when individuals start to develop a perinatal mental illness, the progression of the symptoms is very different. If you have self-limiting condition like baby blues, where women might feel a bit tearful, they might feel easily overwhelmed, they might have some sleep disturbances, but all the symptoms tend to improve over time and eventually they go away. When women develop a perinatal mental illness, the symptoms persist and they become what we say pervasive. So they affect every domain of women's life and they are not improved or ameliorated by practical and emotional support. So even if women have the opportunity to rest or sleep because somebody else is looking after the baby or the baby's asleep, they still can't relax, they still can't fall asleep, and they feel constantly preoccupied, overwhelmed. And if the illness is not treated promptly, the illness can progress, evolve, and women can become severe and unwell to the point of developing psychotic symptoms such as persecutory ideation or auditory hallucinations. And unfortunately, those women whose illness reaches a severe degree are those that unfortunately end up sometimes taking their own life or harming their children.
I know you've touched up already on some of the symptoms new mums can experience, but maybe if you focus a bit on the spectrum of severity, ranging from mild presentations to the more severe symptoms women can present with.
Well, that depends really very much also on the type of illness. As I reiterated initially, we often focus on postnatal depression or postpartum depression, but we must consider that women can develop all sorts of mental illnesses. Some women develop anxiety, panic attacks. Some women might experience an exacerbation of a pre-existing psychiatric condition, such as, for instance, an eating disorder. And also, women who have pre-existing psychiatric conditions such as schizophrenia or bipolar affective disorder, they don't get better in pregnancy, which is what most people believe, but actually they get worse. And in the postnatal period, there is also a significant increase of the risk of relapse. Now, individuals who have mild and moderate symptoms may experience symptoms like sleep deprivation, changes in appetite, feeling easily overwhelmed. They might also feel quite irritable. And there are also symptoms that interest what we call cognitive function. For instance, mental illness can also affect attention, concentration, the ability to multitask, to prioritize. All these functions actually are very essential in adaptation to motherhood. If women, however, suffer from mild to moderate degree of an illness, they tend to, they still function somehow. But when the illness becomes very, very severe, the women find it difficult to attend their day-to-day task. And that clearly makes them feel quite inadequate. And they might start to develop beliefs, for instance, that they are not good enough mothers, that the children will be better off without them. And clearly that's a very dangerous route to take in the course of a mental illness.
Given the impact these symptoms can have on day-to-day life, why is there often a delay in presentation or reluctance to seek treatment?
In terms of identification and recognize the illness, we all know, for instance, that the fear of stigma, the fear of criticism, and sometimes the fear of losing custody of the children may prevent women to disclose their condition. And so these women feel very isolated, very lonely, and this can be very dangerous. It is absolutely crucial to understand that physical health condition and mental health condition should be treated with in the same way. We often advocate for parity of esteem between physical and mental illness. We don't approach and treat mental illness in the same way we treat physical illness. For instance, if individuals have a physical health condition, they immediately seek help. But when it comes to mental illness, for the reason that I've explained before, the fear of stigma, the fear of being criticized, the fear of losing custody of the children, women tend to be quite secretive about their symptoms. They suffer in silence. And this can be very dangerous because eventually, when the illness reaches a severe degree of intensity and those women seek help or they come to attention of mental health services, perhaps at that point it could be too late for the treatment to work effectively. So it is absolutely crucial to be vigilant, to be open, and particularly defeat this culture of shame and guilt. People don't choose to have a mental illness in the same way they don't choose to develop gestational diabetes. And treatment is available and can really change the course of the illness and can actually change the life of families. And therefore it is important for women to understand that there is no blame, there is no shame in it, and they should be able to seek and receive specialist help.
It's a very important point you've raised, that we tend to demedicalize mental health, and women aren't routinely screened for mental health conditions in pregnancy the way we'd screen for physical health conditions. I suspect that translates into lots of missed opportunities to pick up on these issues early on.
So you mentioned screening, and just to give an example, what we do here in England, we train all the midwife and the obstetrician and even the pediatrician to be aware about perinatal mental illness. Often women who develop perinatal mental illness, they don't come across in contact with specialist psychiatrists in the first instance. They usually are assessed and treated by the general practitioner or by the obstetrician or the midwife. And so this is an important point, because those healthcare professionals can actually identify early signs and symptoms and then redirect women to the correct service. In the second instance, it's also important to make women understand that mental illness can be treated, and there are a number of interventions that can be delivered to treat those conditions. And if the illness is caught in time, the treatment doesn't have to be extremely lengthy.
Can you talk to us a bit more about what some of the risk factors are for developing postpartum depression?
So we know, for instance, that women who have a pre-existing mental illness are at increased risk, and so these risk factors are easily identifiable and can be mitigated. And every healthcare professional that comes in contact with such women has a role in helping women to make them aware of the risk factors and then signpost them to the correct services. However, many women do not have a previous history of a mental illness, and they develop a mental illness in pregnancy or the post-delivery period ex novo. So for these women, it's a bit more difficult to identify the risk factors. However, we have to also take into consideration a number of factors which are a bit outside the remit of psychiatry. For instance, many women find the experience of motherhood quite isolating. Many women also can face bullying and harassment in the workplace once they disclose the pregnancy or they take maternity leave. Many women, for instance, cannot access their normal coping strategies, such as exercising or socializing or engaging in leisure activities when they have a young baby. And so all these factors need to be taken into consideration, because they actually could precipitate a perinatal mental illness. Furthermore, we have to also be very open about the fact that there is an incredible societal pressure on young mothers to outperform. The standards are very high. Women are expected to run the household, look after the children, outperform at work, often without very little support. And so for many women, motherhood it's a joyful experience and it's quiet and everything goes smoothly. But for many other women, this type of experience is extremely challenging and can actually be quite isolating. And women, as I mentioned before, they tend to suffer in silence to the point that then the illness progresses to the point where it's very difficult to treat and manage it. And so raising awareness, training all the allied professionals and healthcare professionals involved in women's care in the perinatal period is definitely one of the most important factor to identify, risk factors and mitigate also the risk of women developing antenatal or postnatal mental illness.
Sure, that makes sense. You mentioned the role of stigma as an obstacle to seeking help. What advice would you give new mums on how to break that silence and to overcome the societal pressure that you're supposed to be in a celebratory phase of your life and experiencing nothing but joy?
I suspect that there are two aspects that one should consider. So the first is that it's very important to convey the message that perinatal mental illness is very common. And particularly in the service where I work, which is integrated with maternity service, we really try to conceptualize mental illness as one of the most common medical complications of the pregnancy. So, for instance, women who have diabetes or have epilepsy, they're usually assessed in the high-risk clinic in obstetrics. And so in the same way, individuals who have a pre-existing mental illness or they have developed a mental illness in pregnancy should be treated the same way. So we should convey the message that having a mental illness in pregnancy is not something to be ashamed, but it's something that can happen, that nobody chooses to have, and therefore needs specialist higher treatment. So perhaps this normalization could help women to feel less stigmatized in terms of coming forward with their condition. The second element is that sometimes women feel scared because they don't know what's out there to treat them. Okay, maybe they have some stereotype view of the fact that if you have a mental illness, your children are going to be taken away and you're going to be locked in a madhouse. And this is really not the case.
Following on from that, can you talk to us a bit about the main recommended treatment options for postpartum depression?
We have made considerable advance in terms of intervention. So in the first instance, women with a mild or moderate degree of severity can access a wide range of psychological but also non-psychological interventions. So for instance, we know that cognitive behavioral therapy, either in individual or in groups, is extremely effective in treating most of the perinatal mental health condition. There are also other techniques like EMDR that can be used, for instance, where women have had a traumatic experience in the past and they suffer from the psychological sequelae of this trauma. But more advanced treatment are also on the horizons. Not all women, for instance, feel comfortable in talking to a therapist. And so for these women, we can offer what we call non-verbal therapies, such as art therapy or participatory music. In addition, it is very important to clarify that people have children, not only women. And if a woman has a mental illness, that affected the whole family. And there are some institutions and some organizations that can offer a wide range of intervention that target not only women, but also, for instance, women and the baby, and they look at the relationship with the baby or the whole family. There are two important charity organizations, for instance, in England, the Brazelton and the Association of Infant Mental Health, that offers precisely this type of support to parents to facilitate their journey towards becoming sensitive and responsive parents. And the other big myth that often scares women from disclosing that they have an illness is the fear of taking medication. Now, in some cases, there are strong indications for starting medication during pregnancy or in the immediate postpartum. And it's clearly a very anxiety-provoking condition choice. However, these women should be able to access a specialist consultation with a perinatal psychiatrist so they can make an informed decision in terms of starting, stopping, or reducing the dosage of the medication. But we're very lucky in psychiatry because the vast majority of the medication that we prescribed, with the few exceptions, are compatible with the pregnancy and with breastfeeding, and they're actually effective in alleviating symptoms. So if women are, in a sense, reassured that having a mental illness, it's okay. It's like developing gestational diabetes or thyroid problem in pregnancy. And if they're reassured that intervention is out there available, and this intervention can be easily delivered by a number of trained healthcare professionals, I suspect that the combination of these two elements will undoubtedly help women to come forward and to accept and acknowledge the existence of a mental illness and treat it with the same proactiveness we reserve to physical health condition.
I agree that's an essential point to put across, that there isn't a one-size-fits-all when it comes to treatments, and that these can be tailored for the individual based on their preferences, based on their severity of symptoms. Each woman's presentation is different, and even the same woman can present different from one pregnancy to another. When I speak to patients, I often find there's a hesitation to start treatment. If they're breastfeeding, for example, they're worried about taking medication that can affect the baby, or they're worried about long-term side effects. But there are lots of treatments available. Dr. Miele, can you tell us a bit more about the professionals and services involved when a woman first presents with possible symptoms of postpartum depression?
So that, in a sense, depends very much of where we are. So I'm very mindful, for instance, that I'm not familiar with mental health services or healthcare services outside Europe. But for instance, I'm very mindful of the fact that specialist perinatal mental health service are not common in the rest of Europe. And for instance, in the UK, we're definitely at the forefront, and we have made considerable progress in developing and establishing specialist perinatal mental health services. Obviously, the healthcare professional position in primary care are in an extremely good position to implement those screening and those vigilance that we mentioned before. But once women have been identified as having a mental illness requiring intervention, they should be referred to specialist perinatal mental health services. Those are usually teams inclusive of psychiatrists, psychologists, specialist nurses, occupational therapists, social worker. We have also specialist and very competent administrators, and they, those services, they provide a comprehensive package of care, inclusive of assessment, but also a wide range of intervention, as well as psychoeducation and generic support, not only for the mother, but also for the rest of the family, partners or other children. A number of women, however, may present with very severe and acute perinatal mental illness, and those women are usually not, it's not advisable to treat these women in the community. And again, in England, we do have specialist mother and baby units. Those are effectively psychiatric hospitals with a limited number of beds, usually it's 10 or 12, where women can be admitted with their babies. Now, I don't know of any other hospital that offers this opportunity to admit mothers with their babies. And the reason why they admit with the babies is because the whole point of treating perinatal mental illness is to avoid separation from the baby and also help mother to recover from the mental illness and to strengthen that important parent-infant relationship. Another important element of the service that we provide is training and psychoeducation of all the allied professionals. Because when women are pregnant, they meet a number of healthcare professionals in different settings. And all these healthcare professionals, the GP, the community midwife, the health visitor, the neonatologist, the obstetrician, they must be aware of the possibility that every woman can develop a mental illness during pregnancy and in the postpartum. And therefore, those healthcare professionals plays a really vital and crucial role in nipping things in the bud and ensure that women are detected in the early stages of the illness and can access the appropriate package of care.
Yes, I think this emphasizes the principle that mental health is a discussion that should be normalized more so that it's on everyone's radar. Every point when a woman has an interaction with a healthcare professional is an opportunity to intervene. So it's not really a sole responsibility of one specialist. You mentioned earlier the role of people close to the woman who's suffering with the symptoms, be it their partner or a close relative, and the fact that it's sometimes difficult for them to know what's the right thing to do to support their loved one. What advice would you give on how to care for a loved one who's struggling with a postpartum mental health condition?
Yes, and thank you for asking this question, because this is it's a very, very recurrent theme in our service. For partners and its significant others, it could be quite baffling and puzzling to see the changes in new mothers, and for them it's often very difficult to help. Sometimes, for instance, they feel that the help they give is not enough, is not appreciated. Some women feel that the help provided, the support is not the right way, feel sometimes undermined, or they might perceive the offer of help as a criticism, or as a judgment that perhaps they are not good enough and capable enough to look after the baby. Again, one of the key element is to provide, first of all, a listening forum for partners, and try also to reassure them and provide them also with psychoeducational sessions, because if people haven't specifically read about postpartum mental illness or perinatal mental illness in general, they wouldn't know what to expect. And so it is extremely important to inform partners about the possible progression of the illness, the available treatment, and what to expect. And we work very much with a collaborative model of care. We don't really tell people what to do or what not to do. We work together. We really work according to the preferences of the family, and our role is to empower mothers and their family to overcome the illness with the method with the means that they think is most appropriate for them. There are now in England a number, for instance, of charity organizations that offer specifically support for partners, and there is also some evidence indicating that fathers can develop postnatal depression too, and therefore they need to access assessment and intervention in the same way their spouses or wives do.
Can you tell us a bit more about what other peripartum mood and anxiety disorders we should be aware of? People often don't realize that there's a whole spectrum of different postpartum illnesses that get clustered together under the blanket term postnatal depression.
Yeah, sure. You're absolutely right. So we also have this kind of stereotype image of the postpartum depression. However, as I mentioned before, other conditions like anxiety disorders are also very common in pregnancy. And also, for instance, eating disorders. So many women, for instance, have eating disorders which can be mild or moderate, and they don't impact so much in their day-to-day level of function. However, with the physical changes imposed by the adaptation to pregnancy and the postpartum and the breastfeeding, women feel very conscious about their self-image and their body image, and this can actually make eating disorder even worse. So we know, for instance, that many women actually hide the symptom of eating disorder. But again, it's very important to identify these, because an untreated eating disorder can have detrimental consequences for the outcome of the pregnancy. Some women may develop also psychotic illnesses, for the first time during pregnancy or in the postpartum. Perinatal OCD, for instance, is another condition which is very relatively frequent in pregnancy. So women become extremely preoccupied with ritualistic behavior and have intrusive thoughts. And of course, there are conditions which are mixed. They have picture with mixed anxiety and depression. Another important aspect of the perinatal mental illness to consider is that the course of the illness, it's very different from the course at other time of life. One of the characteristics, for instance, of perinatal mental illness is that the course is very fluctuating and the progression is very rapid. And so women can become unwell, particularly in the postpartum period, within 24 or 48 hours. And that might take aback a healthcare professional and loved ones in terms of how to manage and how to support and help these women. And so we have to be really mindful that every type of illness can occur in the perinatal mental health, in the perinatal period, and we shouldn't focus only on the postpartum, but also in the antenatal period. And in fact, I think it's estimated that 13% of women who are labeled as postnatal depression in reality had antenatal depression as well. And so, with this in mind, we have to be very vigilant for signs and symptoms, not only of depression, but also anxiety, perinatal OCD, eating disorder, sometimes psychosis, and also not only, as I said, in the antenatal period, but also in the postnatal period. And another important aspect to consider is that women who have had a very traumatic childhood and have suffered abuse, they often struggle to adapt to motherhood. And those women, for instance, also need specific and specialist input to help them to adapt to become responsible and responsive parents.
Dr. Miele, as we approach the end of our discussion, I'd like to focus a bit on a positive message to our listeners that people can and do get better, and that there are treatments available that can be tailored to the individual. I was wondering if you can tell us a bit about, from your experience, the prognosis of patients who do seek the right support and what the future looks like for them.
Yes. So I feel very privileged because I've been working at St. Mary Hospital for almost 20 years. First of all, we offer also a preconception advice service. In other words, we help women who are not pregnant, but they're at risk of developing a mental illness, to plan for the pregnancy. And that makes an incredible significant difference in terms of how the pregnancy is perceived and how the outcome of the pregnancy can improve. And there is our service offer a great emphasis also on preparation to parenthood, which is something that in our society we don't do. I find really interesting, for instance, that people might spend hours looking at different iPhone models, and they do lots of research, but when it comes really to prepare for motherhood or parenthood, we don't really put in the same type of research and preparation, but actually it's important to be prepared and to be aware and have realistic expectation about parenthood. And the second point that I would like also to highlight, and I had the privilege to experience, is that I've seen many women who have come to me acutely unwell during, for instance, the first pregnancy, and they came to me in a sense in the later stage of the illness, when the illness was really severe, and sometimes we had to arrange admission to mother and baby unit precisely because they didn't recognize the illness, or they denied the existence of the illness. They were hoping that the illness will go away by itself, and it didn't. And for me, the greatest achievement and the greatest privilege is to see women coming back to the service with the second pregnancy, during the second pregnancy and the third pregnancy, and having a completely different experience. In that case, we work really with a preventative model. We adjusted the medication, we resume the psychological treatment, we see the family again, we link the women with all the community resources available, and it's extraordinary to see how the same women can go through the same experience of having a baby with a completely different outcome. And I think that even if things are never going to be perfect, we can still ensure with assessment, treatment, psychoeducation, and genetic support, particularly with being compassionate towards our patient, we can always ensure that they have a positive experience of motherhood, and we try to make a joyful experience, having a baby for everyone that comes to our service.
Yes, indeed. Like you said, it's not necessarily about having the perfect experience. It's about accepting imperfection, and just being compassionate towards themselves and seeking support when it's needed. Dr. Miele, thank you very much for joining us today. This has been a very useful discussion, and hopefully discussions like this mean more women don't suffer in silence.
Thank you so much for having me, and I wish this important charity all the best. And I hope that with this, many more women will come forward and disclose their illness and receive the right type of treatment.